Whether you live in a big city or rural countryside, we all need medication at one point or another. And while pharmacies have always been the go-to option, they're becoming increasingly difficult to find. Communities all across America are facing a threat called pharmacy deserts.
A pharmacy desert is an area, whether in an urban setting or in a rural setting, where patients don't have access to readily available community pharmacies.
That's Justin Macy, the Digital Health Senior Manager at the National Association of Boards of Pharmacy. He says pharmacy deserts have been occurring for quite some time.
I think there's always been a historical trend of lack of access in rural areas, just based on the idea of finding a pharmacist, putting them in an area, and people being very, very spread out. But I think there's a more recent trend of there being lack of access to pharmacies in all sorts of areas that you wouldn't necessarily think that to be the case because of pharmacy closures.
Areas like big cities such as New York and Chicago. The idea of geographically scarce resources began in the 1970s, according to Dr. Walter Mathis, an assistant professor of psychiatry at the Yale School of Medicine.
And actually started with thinking about the USDA and food deserts. In the early 90s, that idea was translated into kind of health-specific things, so health deserts, and pharmacy deserts being one of those. And so generally speaking, it's a way of geographically identifying areas that are underserved or challenged in their access to specific health resources, and in this case, pharmacies.
But why are pharmacies closing? While there are a few reasons, Mathis says one is due to an invasion of large corporations.
So big pharmacy chains coming in and either developing their own stores or buying smaller chains is a way to increase kind of a constant corporate revenue, puts a lot of pressure on smaller pharmacies. But in the end, oftentimes you'll see even within those corporate development structures, they come in, occupy a particular area, then start, once they've kind of established or sometimes run out the mom and pop, so to speak, then they start kind of closing down their own stores when they realize exactly what the supply and demand is and how they can most efficiently serve those that they take in as clients or patients and with the fewest number of stores and workers.
Which leads to issues for the consumers that no longer have a pharmacy close to home. In fact, you don't even have control over where your existing prescriptions will be filled because you don't actually own them.
Your prescription is owned by the provider who prescribed it, and then after the fact, after it's filled, is owned by the pharmacy. So the pharmacy is able to sell those prescriptions to another pharmacy that maybe isn't your first choice or maybe isn't your second choice, and your records will be there as well. So you kind of have a new relationship with a new pharmacy, and you didn't have any control over it.
Macy says the laws differ from state to state, but in most cases, you have no choice over where your prescriptions will be sent after your pharmacy closes down. And according to Mathis, as the distance between you and your medication grows, the likelihood of you actually taking it decreases. But it's not just access to medication that's become a threat. Pharmacies have been gradually increasing their role in public health over the years, a trend that Mathis says skyrocketed during the pandemic.
Now it's very common for a pharmacy to be thought of and used as a place to get testing for diseases, to get vaccinations, sometimes to get direct patient care. And that on top of already what they're doing with counseling, over-the-counter medications, all these other healthcare services they were doing, it just seems to be growing and growing.
And it's not a coincidence. Mathis says pharmacy associations created a plan to become a more active part of healthcare years ago. He thinks it's a great option that helps fill the gap of America's centralized system.
We have a lot of people who are getting underserved and have poor access to primary care in general. So it kind of makes sense that some aspect of the healthcare market would come in and try to fill some of those holes. And in a way, the pharmacies are one of the groups that are doing that most successfully. So it's not just access to your meds and filling your diabetes meds. It's also difficulty accessing your vaccines, testing, thinking about your blood pressure, keeping it monitored, all these things that pharmacies are now doing day in and day out that maybe they didn't even do 10 or 15 years ago.
So with the rise in pharmacy deserts, people are losing access to so many basic healthcare needs. But before we can find a solution, Mathis says we first have to figure out the scope of the problem. He recently published research in the Journal of the American Pharmacists Association that pinpoints pharmacy deserts across large cities in America. The team studied Los Angeles, New York, Houston, and Chicago. And though pharmacy deserts have been researched for more than a decade, Mathis's paper is the first to factor in public transit. Prior to this paper, all other research defined pharmacy deserts by how the USDA chose to define food deserts in the 1970s. That's by distance, not mode of travel. However, Mathis says this definition doesn't accurately reflect the reality that many people don't own a car, especially in large cities.
The agreed upon definition that we all kind of use in our various research projects are directly translated from the USDA work 20 years ago now. And again, they were kind of limited by as the crow fly distance, because computationally, not to get too nerdy about it, those are significantly easier to do than, say, drive distance or drive times, which, we in the kind of the post Google Maps era have just taken for granted.
We can find directions to the nearest grocery store in no time at all, but imagine having to find the directions to several million stores. Mathis says his team was able to speed up the process by repurposing technology they'd used in previous projects. They then calculated pharmacy deserts by looking at both car travel and public transit.
We saw overall a reduction in the number of what we call pharmacy deserts with the new time-based definitions, although we felt pretty confident about them because the distribution amongst the predominant race or ethnicity of the neighborhoods matched back to the same distributions we'd seen in previous work that used distance-based definitions.
Meaning that while there may not be as many deserts as previously thought, the impact remained mostly the same. Interestingly, under the time-based definition Mathis used, New York City showed no pharmacy deserts at all. He credits the city's public transportation culture for the results.
I think on the other side, when you factor that in for Houston and Los Angeles, you actually found that there are more pharmacy deserts than if you assumed everybody had car access, which of course one can't.
Mathis thinks the rise of pharmacy deserts in these cities is directly correlated with their wide use of personal cars versus New York and Chicago's emphasis on public transportation. And though he says the easiest solution would be to increase the public transit options in these cities, he knows that's the hardest and least likely outcome. Other groups have been working on a different angle by proposing legislation to subsidize the construction of new pharmacies in underserved areas. However, Mathis thinks a different approach may be more effective.
It's incredibly expensive to open up a new pharmacy. The estimates are between $800,000 and $1.5 million to open up a new pharmacy. The percentage of those monies that would need to maintain a pharmacy that was maybe the one pharmacy keeping a particular area from going into a desert would be, I think, probably a more savvy way to think about a first batch of policy interventions.
Which is what Mathis and his team are working on now. They're calculating which areas are at risk to become pharmacy deserts and researching policies that could help support the existing pharmacies stay afloat. Macy says another answer that's grown in popularity are online pharmacies, but they're not a perfect solution.
They've been around for quite some time, actually. It's just a matter of our familiarity and our comfort in using them. I would say, generally speaking, that it's a dangerous area out there. You have to be careful of who you choose. About 95% of all websites selling prescription drugs operate illegally.
Macy says illegal operations usually violate three big factors. The first are websites that sell prescription medication to customers without a prescription. The second violation is when a website sells unauthorized drugs that aren't FDA approved or regulated. And the third sign of illegal activity is a website pretending to be a pharmacy but isn't licensed in the patient's jurisdiction, which is required in almost every U.S. state. Sometimes illegal online pharmacies will offer to ship globally, which Macy says isn't possible.
Pharmacies aren't licensed everywhere in the world. It's not a possibility. There's no one license you get that makes you good everywhere. So that's another big red flag as well. Likewise, you'll see many illegal online pharmacies say they're coming from Canada and put maple leaves on their websites. They aren't. Most of those sites have no affiliation with Canada. That's another red flag that I would look for as well.
But buying medication online is a great option if you know you're buying from a licensed pharmacy. Before you trust a website, Macy says there are a few red flags to watch out for.
So anytime you get bonus pills, that's not a real thing in pharmacies. This sounds funny, but many of the illegal online pharmacy networks, these illegal websites are often ran by large criminal network organizations. They own thousands of pages, not single pages. It's kind of a larger endeavor. But what I would say is they often have bonus pills that you'll see while you're checking out, irrespective of what med you're picking and getting, you can elect to have bonus erectile dysfunction medication added to your cart without a prescription. And depending on how much you spend on the rest of the drugs, they will give you more or less of that drug. That's not a thing you ever experience. You can't get a second drug without having a prescription from a regular pharmacy.
It may sound obvious, but studies have shown that even pharmacists can be duped by illegal websites.
If you go and you ask pharmacists to figure out which ones are legal versus illegal, pharmacists still fail that test 17.5%. And they're pharmacists. If you look at the rest of professionally licensed healthcare fields, and if you look at consumers, it's closer to 50-50 as to whether they can tell whether or not it's a legitimate or illegitimate site.
Fortunately, you don't have to guess. The National Association of Boards of Pharmacy's website, called safe.pharmacy, allows you to paste the URL of an online site to see whether it's licensed and safe. And though this online option can increase access to pharmacies, Mathis says it won't fix the issue entirely.
A lot of patients who would most benefit or are most burdened by these access issues to pharmacies are the ones least likely to have reliable internet access, reliable internet utility or tablet or computer, or most importantly, the acumen to really navigate these online pharmacies, which can be quite difficult. It's a little bit of a not the catch-22, but kind of a complication that those who might most benefit from it are sometimes the ones who are most challenged to use a resource like that.
Overall, Mathis thinks the lack of pharmaceutical access points to a greater healthcare issue in America, one that he believes could benefit from investing in robust public transit systems across the country.
Someone has a hard time getting to a pharmacy, which are kind of granular and kind of almost everywhere compared to say a primary care clinic. You can only imagine the difficulties around accessing some other resources. And then, of course, beyond healthcare, legal, financial, and any of these other kind of institutions that require physical access are going to be tempted to factor in similar kind of analyses around X desert, bank desert, primary care desert, food desert, any of these things, which I think are going to be benefited by having a more robust public transit system as well.
You can find more information about Justin Macy, Dr. Walter Mathis, and all of our guests on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. I'm Reed Pence. Coming up next week on Radio Health Journal.
Can we be perfect? No. Can we be better than what we're doing with the time that we have available? Yes, I believe so, absolutely.
Why doctors say healthcare needs to rethink its moral center.
Then a new hope for men with advanced prostate cancer.
The really good news is that 30% 5-year survival, we're seeing it increase. I've had patients who've lived 6 and 7 years.
All that and more on Radio Health Journal.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
Workers are finding that even under all this pressure, working for a company that's making an immense amount of money, they have to choose at the end of the month between groceries or rent.
Better understanding the current labor revolt. Then,
I'm saying, go ahead. The world will see what you're going to do.
The power of photography during the civil rights movement. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.